Hello and welcome to my presentation for the 2021 Research and Creative Achievement Conference. My name is Alessia Pesatoro and I am part of Merrimack College School of Health Sciences working towards my degree in athletic training. Today I'll be talking about Osteochondritis Dissecans, which is a case I looked at during my clinical rotation at Excel Orthopedics. So some background on the condition. It develops most often in children and adolescents in the knee, ankle, or elbow, but it can occur in any joint in the body. It is also only most common in one joint, but in this case, the patient had it in both of her knees. A small segment of bone begins to separate from the region due to lack of blood supply, which in turn causes a lesion. And when the bone dies, cartilage covering it cracks and may break loose, which causes a fragment. In most children, the affected bone is able to heal on its own due to them still growing. However, in grown adults, the lesion has a greater chance of separating or detaching, which may require surgery. And the true cause of this condition is unknown, but it's predicted to be from repetitive trauma, such as high-impact activities. Some symptoms the patient can present with are pain, swelling, locking, catching, giving way, and decreased range of motion. So this sounds very similar to other conditions, hence why history and mechanism of injury is very important to determine the diagnosis. And underneath, I inserted a picture of the most common site for OCD lesions, and as you can see, it's very close to the medial meniscus. So for the patient, she's a 35-year-old female who's married with 2 kids and works as an esthetician, so her job requires her to be on her feet during the day for extended periods of time. She's been active in sports since childhood and mainly competed in soccer as well as figure skating. She struggled to manage pain and activity with her condition since she was a teenager, suggesting that she had a lesion during adolescence that did not heal as she transitioned into adulthood. She recently, during a workout, stepped wrong, which caused immediate pain and swelling and inability to flex or extend the knee. She also noted that about 3 to 4 days ago, she had severe sharp pains and upon standing felt something shift that gave her full range of motion. So it's probable that the fragment flipped into a position that wasn't impacting the femur, which allowed her to gain that range of motion. For intervention and treatment, she was referred to the orthopedist to get x-rays. And imaging is a gold standard to diagnose this injury, so we're able to see the size and location of the lesion. And as we can see in her x-ray, I've circled in red the lesion in her femoral condyle. She also had some marrow edema and a subchondral cyst. So her lesion ended up being 33 millimeters or 3.3 centimeters, which is on the larger side. So she was recommended to get a surgical procedure, which is the left knee osteochondral allograft reconstruction of the medial femoral condyle. Other patients also have non-surgical options, and this is best for growing children, again, because they're able to heal on their own. So this includes rest, activity modification, and immobilization. However, they do need to be monitored routinely to assess their symptom improvement as well as the lesion. This also allows for preservation of articular cartilage. For surgical interventions, we have 4 options. The goal of this is to replace damaged cartilage with hyaline-like tissue. In the procedure for marrow stimulation, they drill or microfracture the subchondral bone to allow cells from the marrow into the defect to build fibrocartilage. And this is the first line of treatment in small lesions that are less than 2 to 3 centimeters. For autologous chondrocyte implantation, that is recommended for lesions 2 to 10 centimeters, and they take healthy chondrocytes from a non-weight-bearing region, debride the calcified cartilage, and create walls of healthy tissue with the new chondrocytes. In an osteochondral allograft, what the patient received. It is recommended for lesions larger than 2 centimeters, which she had. They take cartilage from a cadaver and drill out the appropriate size and insert it to where the lesion was in the patient. And it is the same procedure in an autograft. The only difference is that it is taken from the patient themselves, so disease transmission is reduced. For her outcomes, she was sent to rehabilitation physical therapy following her surgery. So in phase 1, weeks 0 through 6, the main goals were to increase range of motion, decrease any swelling as well as pain. And to do that, we worked on passive range of motion of the knee for extension and flexion, patellar mobilizations, hamstring gastroc stretching, and quad strengthening. She also came to us in a hinge brace, locked in full extension, and she was non-weight bearing for 2 to 4 weeks, and she moved to touchdown weight bearing at 3 to 4 weeks, and partial weight bearing 25 to 50% of body weight at 6 weeks. To move on to phase 2, weeks 6 through 12, we implemented weight shifts, mini squats, step ups, some more weight bearing exercises, and knee flexion should be around 120 degrees at this point in time. We also were able to discontinue the brace, and she was at 75% weight bearing with crutches at 6 to 7 weeks. At 8 to 10 weeks, she moved to full weight bearing. To progress to the next phase, she needed to be at 20% of her hamstring strength and 30% of her quadriceps strength, which she was at, thankfully. So at phase 3, weeks 12 through 26, we want her to be at 125 to 135 degrees of knee flexion. We utilize lunges, open kinetic chain exercises, walking on treadmill, and wall squats. And then to move into the final phase, she needed to be at 80 to 90% of strength bilaterally. And during these weeks, we focus on more sports specific, so agility and balance drills, increase resistance on current exercises, and really emphasize lower extremity strength and flexibility. If she was to return to sports, depending on the type of sport, would determine her return. So for low impact sports, such as skating and cycling, it's around 6 to 8 months. Moderate impact sports are 8 to 10 months, so any aerobic activity. And high impact sports, such as soccer, is 12 to 18 months. So at the start of her treatment, her passive range of motion was 85 degrees of flexion. She was at a 6 out of 10 pain, had 4 centimeters of edema, and 100% on the lower extremity functional scale. So she was unable to do any daily activities. And then at week 8, the patient's passive range of motion flexion is 136, so she gained full range of motion, and 0 degrees of extension. She's at 1 out of 10 pain at the worst, 0 centimeters of edema, and 67% on the lower extremity functional scale. She's also increased her strength in knee flexion to 4- out of 5 and knee extension to 4 out of 5. To construct her rehabilitation plan, we utilized the Advanced Continuing Education Institute website. They provide educational courses and protocols for several surgeries for any joint within the body. So there's no true gold standard rehabilitation protocol for post-op for this specific treatment, but general guidelines are that all protocols should include a full non-weight bearing for 6 to 12 weeks to protect the site, as any extra load or shear forces could damage the surgery and have negative outcomes on treatment. So although this condition is not common that we see in clinical practice, understanding the various types of lesions that occur, as well as how age can affect treatment decisions, is critical to provide best care to the patient. If this injury is suspected, proper referral and communication with healthcare personnel is required for an accurate diagnosis. And as an athletic trainer with this knowledge and flexibility of rehabilitation, we're able to effectively provide treatment as well as to lower the healthcare costs for the patient.